Good morning, good afternoon, and good evening. And thank you very much again for letting me know that you guys don't see the screen. Now we're gonna restart. Alrighty. So, all right. So today's topic is about acute kidney injury, very high yield topic in the licensing exam. So I do encourage you guys to invest a little bit of time, go through the notes that you have in Jala Academy. Again, we have notes and we have Jala notes. I'm not saying the notes is not sufficient, but I would encourage you guys to do the Jala notes, which has more information. It is more exam focused, and you can find more information and topics or subtopics or subtitles that you might not have it in any other notes or books, which we will cover it, or we did cover it in the Jala notes, and we will cover it today in this lecture, and also we do some cases accordingly. So again, very high yield. Please do this before you go for the exam, because you will definitely get a few cases out of acute kidney injury. Okay. So at the end of this session, the learning objective is that you guys, by the end of this lecture, should be able to understand the KDIGO criteria, but most importantly, you should be able to diagnose the pre-renal, renal, and post-renal cause of acute kidney injury. So acute kidney injury, it could be pre-renal, it could be renal, which is also called intrinsic, and it could be post-renal. By using some tools, like for example, history, based on the history, the clues, which I'm going to tell you that what are the clues. If you see it in the history, you should suspect that this is pre-renal rather than renal or post-renal. Same thing or vice versa. So volume status, very important. And also urine finding, very, very important. For example, in urine sediments patterns, you would be able to tell by the findings in the urine that this patient may have acute tubular necrosis or acute interstitial nephritis or glomerular nephritis. Very easy. If you have the findings and then it matches the urinary finding, which we will discuss it, and we will tell you, I will tell you that which one is very specific for which condition, then it should be very easy for you to know, oh, this is acute kidney injury, but it is renal. Oh, this is acute kidney injury, but it is post-renal or pre-renal. Choose the best initial management action. By far, this would be the most commonly asked question. So if they want to test you, this would be the question. Most likely, I'm not going to say like 100%, but most likely this would be the question. That what is, like they give you a scenario about acute kidney injury, then you have to be able, based on the history or based on the scenario, you have to be able to tell that this case is pre-renal. So what is the best initial management? Fluid or decongestant or decongestion treatment, or stop drugs or supportive treatment, or decompress strategy or therapy. Recognize complication based indication for urgent dialysis, and also avoid common exam traps. For example, misreading the fraction, the function, the FENA on diuretics, missing obstruction, giving fluids, and congestion, as opposed to using the decongestion treatment. All right, so very, very important slide. For acute kidney injury, it will present, or you have acute kidney injury if one of this is present. For example, you have a patient, and when you do the serum creatinine, it is more than 26.5 micromillimole per liter within 48 hours. Or there is an increase by 1.5 times the baseline. Whatever the baseline is, it is increased by 1.5 In some cases, it might be even double. But as high as more than 1.5, even if it is 1.6 uh, times the baseline or more than the baseline or normal range, then you have it. Or the urine output, if it is less than 0.5 milliliter per kg per hour for 6 hours. Then the staging, stage 1, stage 2, or stage 3. So you have the findings that you need to memorize it. For example, if it is more than 26.5, again, we did discuss this. And also, if it is 2 to 2.9, or if it is, the most important part is here, right here. If it is 3 or above, or dialysis, this part. And for the acute kidney injury, we will discuss it in details in the next slide. I think, probably after this. So for the acute kidney injury triage, what do we do step by step? So we can confirm it, or we can confirm the acute kidney injury by doing a trend of serum creatinine and urine output. Okay, what is next? Once it is confirmed, my next step would be bladder scan or Foley and ultrasound. The first best thing after acute kidney injury, once you diagnose it or confirm it, it will be to treat reversible conditions. For example, if it is an obstruction, then the best treatment will be Foley catheter or nephrostomy. Just decompress. That is the best thing that you need to do after confirming. If it is not post-renal, then you can think about the rest and treat accordingly. What else you need to do is assess the perfusion. Check the volume, check the medication. You cannot forget about medication. Anyone with acute kidney injury, there are certain medications that you have to ask, or you have to have them in mind. For example, non-steroid anti-inflammatory drugs, antibiotics, for example, gentamicin, and so on and so forth. And also AC inhibitor or ARBs. These are the medications that you need to ask, or serum glucose co-transporter 2 inhibitor. These are the medications that you need to ask, or it has to be in your mind when you're dealing with acute kidney injury, because in most cases, they could be the reason or the trigger for the acute kidney injury. Urine sediments. That is the best thing that helps you and makes your life very easy if you know the urine sediment and you have the result. So if it is granular cast, whether it is WBC cast or RBC cast, we will discuss in details. So these are the things that helps you, whether it is pre-renal, whether it is renal, or whether it is post-renal. Or if it is renal, what type of the renal or intrinsic cause of the acute kidney injury. Urine sodium osmolality, Fe sodium diuretics confound, and act immediately. So based on the reason or based on the cause, you need to act. If it is, for example, dehydration, for example, it gives you a scenario about someone that who has acute kidney injury after the patient had a severe bleeding or a heavy bleeding, or the patient had vomiting, diarrhea, and now the patient has acute kidney injury. So fluid. But it is different from cardiorenal syndrome. For example, if the acute kidney injury happens due to heart failure and the patient has pulmonary edema, in this case, you don't have to overload the patient because the patient is already fluid overload, right? So in this case, and instead of using fluid, you use the furosemide, or you use diuretics to get rid of the extra fluid in the body. So it means that fluid is not always the best initial treatment for the pre-renal. In most cases, it is, and it's an immediate treatment. But remember, you have to be very smart to tell whether it is pre-renal or post-renal or renal. Not only that, do I have to start the fluid or not? Or something that's completely opposite of fluid, for example, furosemide. Or in that case, it will be decongest or decongest therapy. Stop nephrotoxin. Always, again, as I mentioned before, that you cannot forget about medication. Whatever medication they're using, stop it, especially if it is nephrotoxic. For example, PPI, for example, gentamicin, for example, non-steroidal anti-inflammatory drug, for example, ARBS, AC inhibitor, for example, the patient have metformin. If the patient is taking, for example, sodium um, glucose co-transporter 2 inhibitor, whatever, stop it. There is a mnemonic that's called SAD-MANS. We will go through that. Always ask if this is this pre-renal, renal, or post-renal. Then treat the driver and complication. Driver means whatever the cause is. Is it dehydration? Is it CHF? Is it sepsis? Is it obstruction? So treat that and the complication accordingly. So this is the flow chart that I made. I think if you have this chart and go through this, this makes your life very easy. You would know everything about acute kidney injury. So suspecting acute kidney injury, now I have a patient and I think my patient might have acute kidney injury. Now, how should I treat my patient? I cannot treat my patient unless I know what type of acute kidney injury it is, or what is the real cause of acute kidney injury. Is it pre-renal? Is it renal? Or it is post-renal? Okay, if it is renal, I should be able to tell from the history. For example, for pre-renal, they usually give you a scenario. The scenario will have a mnemonic, which we will go through, that is called DOT. DOT. Dot, the patient will have dry mucus. Or the patient will have oliguria. The patient will not have enough urination. Or orthostatic changes. For example, the patient has hypotension while the patient stands up from sitting position. And what is T? The patient has tachycardia. So if you have anything that matches this dot, you know that this patient has dehydration and it is pre-renal. Or if you have a patient who has CHF, who has cirrhosis, who has, for example, volume depletion or vomiting, diarrhea, anything that leads to dehydration, okay, now I know what kind of acute kidney injury I'm dealing with. It is acute kidney injury and it's pre-renal. So if it is due to dehydration, I'm gonna hydrate my patient. But if it is something that's cardiorenal, I mean CHF caused the acute kidney, I cannot give more fluid. Now I'm gonna use furosemide. I'm gonna use diuretics. I'm gonna take out the extra fluid. Obviously, whatever you do, you stop the offending medication. If my patient is taking that non-steroidal anti-inflammatory drug, I will stop it. Those all has to be like a package. Stop the offending medication, treat the cause. Now they give you another scenario. They give you a scenario of somebody who has sepsis. Usually, for the intrinsic, I'm not saying always, usually they give you a scenario of someone with a sepsis, and then the patient develops the sign and symptom of acute kidney injury. And they will give you a very specific urine finding. For example, they will give you a pigmented RBC, or they give you, for example, RBC cast, or they give you a granular RBC or cast, sorry. So these are very specific for acute tubular nephrosis, or RBC cast is very specific for glomerulonephritis. So now I know that I'm dealing with renal cause of or renal type of acute kidney injury. So what do I do? What caused this condition? If it is sepsis, I treat the sepsis. If it is nephrotoxic medication like gentamicin, I will stop the gentamicin. So in all cases, whether it is pre-renal, renal, post-renal, we have to ask about the medication and stop the offending medication, whatever it is. For example, for post acute kidney injury, what kind of medication can cause post-renal? The alpha blocker, right? For example, finasteride. Those stuff sorry, other medication and finasteride would help with them. So there are some medication that also cause the post, but usually for for post acute kidney injury, it will be the tumor or the stone. We have a mnemonic for it, which is called stone. So usually there will be an obstruction due to stone or malformation or tumor or a stone. So now I give you another scenario about post-renal. Usually for post-renal, they give you a scenario of an elderly, not only elderly, somebody that has been suffering from BPH. Or they give you a scenario about somebody who is elderly and recently had a surgery. And now the patient cannot pee. The patient has no urine output. So you know that this acute kidney injury that happened, this increase in creatinine that I see, uh, and this decrease in urine output that I see, so this acute kidney injury is due to obstruction. It could be a neurogenic bladder. It could be benign prostatic hyperplasia. It could be tumor. It could be a stone. So whatever it is, I have to open the way. I have to decompress. Okay. So if you know this flow chart, you should be good. You know everything about acute kidney injury. Not everything, like almost everything that you are required to pass an exam. So now I made a mnemonic to make it very, very easy for you guys to understand what causes the acute kidney injury. So remember, P for P, pre-renal perfusion issues or problem. P for P, pre-renal perfusion issues. R for R, renal tissue damage. Anything that damages the renal itself. P for P. Sorry, hold on. Persistent obstruction. So persistent obstruction uh, after the kidney itself. Okay. So now for pre-renal, I made a mnemonic volume. So volume for pre-renal, gift for renal, stone for post-renal. So what is volume stands for? V stands for volume loss, whether it is bleeding, whether it is GI bleeding like diarrhea, vomiting, whether it is dehydration, whether it is burn, whatever that leads to volume loss. Okay. Now, what is O stands for? O for output low. Anything that decreases the cardiac output, for example, heart failure, shock. L, low SVR or pressure, sepsis, anaphylaxis. U, underfelt or cirrhosis nephrotic syndrome. M for medication like ACE inhibitor, ARBs, diuretics, whatever causes the hypoperfusion or pressure. E for afferent tone. So out of all of them, these two are very, very important to remember for the licensing exam. Usually they may ask you that how the non-steroid anti-inflammatory drugs causes the pre-renal acute kidney injury by constricting the afferent, and how the ACE inhibitor or ARBs causing the acute kidney injury, pre-renal acute kidney injury by dilating the afferent. So non-steroid afferent constriction, non-steroid anti-inflammatory drug, afferent constriction, but ACE inhibitor or ARBs, efferent dilation. And they both have been in so many question banks. So I do recommend you guys to remember this, and I make it red, okay? Now, intrinsic renal or inside kidney, or R for R, renal issue, renal itself, renal tissue injury. So G stands, so there's a mnemonic for it. What caused the renal or renal intrinsic acute kidney injury? It is GIFT. G stands for glomerular causes, for example, glomerulonephritis, hematuria, proteinuria, RBC cast, which are very specific for this condition. And I stands for interstitial, like acute interstitial nephritis. Usually for that, the patient will have uh, started would have started, for example, the certain drugs like PPI, non-steroidal anti-inflammatory drug, and beta-lactam, gentamicin, stuff like that, usually beta-lactam, and fever, rash, eosinophilia. There is a triad for it. We will discuss it in details. F stands for tubular necrosis or failure, which we call it acute tubular necrosis. And T stands for thromboevascular. Thromboevascular, usually for this one, they may give you a history of somebody with a very low platelet, uh, 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 TTP or hemolytic uremic syndrome or atheroembolic. Usually, out of all of them, I have seen this one very commonly tested in the question banks. So atheroembolic, if they give you a scenario about someone that who has acute kidney injury, they will give you first in the scenario, they give you history. How they give you history? That recently this patient, like maybe a few days ago or a week ago, the patient had a major surgery. And now the patient has acute kidney injury. And not only that, the patient has eosinophilia. Remember that we have eosinophilia and nephritis too, but there's a difference. They have different type of rash, but this one will have livido reticularis. I will show you the picture. It is very specific to minor vessels under the skin that they get damaged. And also, yeah, same thing. So they will have some sort of big surgery, especially aortic surgery, and now the patient has acute kidney injury. Not only that, the patient has skin changes, which is livido reticularis and eosinophilia. Okay, malignant hypertension, renal vein thrombosis, or they may only give you a blue toe. That's also very commonly mentioned in the licensing exam. Now, for post-renal, there's a mnemonic that is called STONE. S stands for stone itself. T stands for tumor. O stands for obstruction or obstructed prostate or benign prostate hyperplasia or prostatic cancer. N stands for neurogenic bladder or retention. E stands for external compression or structure, for example, pregnancy, and so on and so forth. So now for the post-renal acute kidney injury, the things that you cannot miss. Why? Because they're reversible. Do it as soon as possible, and the patient will get better. Two things that you need to know about acute kidney injury when it comes to pre-renal and post-renal. They will improve really rapidly within 24 to 72 hours as soon as you start the treatment. But for the renal, it will improve, but it will not be rapid. It will take time. It's not as quick as pre-renal and post-renal. So for the pre-renal, if you start, let's say the pre-renal acute kidney injury is secondary to dehydration and you start isotonic fluid therapy, as soon as you start IV hydration, the patient will start improving within 24 to 72 hours. For the post acute kidney injury, when you start decompressing, for example, as soon as you apply the Foley catheter, as soon as you start the nephrostomy, the patient will start improving and the creatinine will start to normalize, as opposed to renal. Renal will improve, but it takes time. It's not as rapid as pre-renal and post-renal. Okay, so these are the things. Again, once you confirm acute kidney injury, the first thing you need to do, see if it is reversible, if it is the post-renal, because by applying Foley catheter, everything goes back to normal. It's reversible and it's quickly improving the patient's condition. Okay, that is something that you need to pay attention. So high yield red flags. Think obstruction. When do you think about the obstruction? You have a patient. The patient has acute kidney injury. Now, what makes you think that it might be obstruction? If the patient has anuria, one clue. These are the clues that helps you to suspect the patient might have obstruction. First, my patient does not pee. As I mentioned before, the patient is an elderly, went to the surgery. Now the patient is not peeing. So the patient has anuria, right? So if the patient is not peeing, this should suspect you that the patient might have obstruction. Two, usually in this scenario, I'm not saying it doesn't happen to young generation, but usually in the scenario, if they want to test you on a post-renal, they will give you somebody elderly and usually male. Please mute yourself, everybody. Dr. Agnes, you came late and your mic is on. All right. Where was I? So this is what happened. Please, when you enter the class, mute your mic. It is really distracting. Okay, I think I was talking about. All right. Oh, elderly. Okay. So anuria, and usually they give a scenario about someone that who is elderly. And usually if they want to test you on past renal, they not only give you an elderly, they will give you a male patient. Why? Because it's more common in male rather than female. Again, I'm not saying it's not happening to female. It is, but it's more common in male. I'm not saying that doesn't happen to the younger generation. It will, but it is more common in elderly. And not only that, the patient is not peeing, the patient is elderly, and the patient has suprapubic pain and palpable bladder. It means the urine is in the bladder, but it's not coming out. So it should tell you something that there is a problem with that. There is a problem with the extraction way. So there might be something obstructing. And high post void residual, obviously. And solitary kidney, this could be also a reason. Pelvic malignancy, recent pelvic surgery is another clue that should raise suspicions about post-renal acute kidney injury. And what is your next step? So, sorry, ultrasound showing hydronephrosis, obviously. So it's going to just give it away, make it too simple. So what is the next best step? If you suspect, ultrasound. If you suspect, do a scanning and Foley catheter. Okay? An ultrasound is the next step because it shows if there is any obstruction, and then you do the Foley catheter. Renal ultrasound to assess for the hydronephrosis and decompress upstream, stent or nephrostomy for the bilateral ureteric obstruction. Post-obstructive diuresis may follow decompression, monitor volume, and electrolytes. Now, pre-renal acute kidney injury. If you notice, we jump right away to post-renal first. Why? Because it is reversible. It's very quick to know, very obvious clues that helps you to suspect it. And as soon as you start decompressing, the patient starts to improve. That's why those are the reversible, and you have to, as soon as you suspect acute kidney injury, the next step should be, is it post-renal? If it is not post-renal, then you come back and think about acute renal, pre-renal, and renal, okay? So and instead of going A, B, C, we start with C after we confirm the diagnosis. Now, so we're talking about the pre-renal. If you remember, I mentioned there is a mnemonic, which is called DOT. So if there's a volume depletion, which is the most common reason for prerenal. Why? Because prerenal acute kidney injury happens due to dehydration. So there should be a volume depletion. And how do we know? What are the clues in the scenario that I should know this patient is dehydrated and dehydration led to acute kidney injury? They gave you a scenario about somebody that who has dry mucus, who has orthostatic, who has oliguria, who has tachycardia. Dot. D stands for dry mucus, O stands for orthostatic changes, oliguria, and T stands for tachycardia. For example, Ahmad had, for example, severe vomiting and diarrhea. Now, when he stands up, he falls down, and when you check his mucus is dry, and he has tachycardia. And now, when you check, the creatinine is above 2.6, or it's around 28, right? So you know the patient has what? Acute kidney injury. So what kind of acute kidney injury? Pre-renal. Why? My patient has orthostatic, the patient has oliguria, the patient has orthostatic change, my patient has tachycardia. So my patient is dehydrated. What should I do? Start isotonic hydration. Okay? One more thing that's very important to differentiate between pre-renal and renal is the FeNA. This one in pre-renal, it will be less than 1%, as opposed to renal, which it will be more than 2. Okay? So again, they give you a scenario, for example, Ahmad, vomiting, diarrhea, now has orthostatic changes, now the patient has dry mucosa, sorry, and now the patient also has tachycardia. The FEA is less than 1. What is the diagnosis? Pre-renal acute kidney injury. If they give you a scenario like the same thing, because this one can happen due to shock as well, due to sepsis shock, it can happen. Pre-renal can happen. So they may give you a septic shock, and then the FEA is less than 1. It is pre-renal. But if they give you a scenario like the patient has shock, septic shock, now the patient has FEA 3. What is the diagnosis? It is renal or intrinsic acute kidney injury. So this is the best tool for differential diagnosis between pre-renal and renal. Remember it. They might even ask you. And creatinine improves usually within 24 to 72 hours, as opposed to renal, which will improve, but not as rapid as pre-renal. So it will take its time, okay? So high yield traps, remember, dehydration, non-steroid anti-inflammatory drug, AC inhibitor, diuretic can precipitate sharp GFR drop. So AC inhibitor, what it does, I just mentioned it. Remember, it's very important. So it dilates the efferent arterioles, okay? And since the patient is on non-steroid can cause constriction of afferent arteriole. Again, this might be in the exam. And the patient is on diuretics. So the dehydration reduce the volume, and kidney cannot maintain the GFR. And that's why the pre-renal acute kidney injury happens. Now, best management. Best management. Now, if it happens that you have the acute kidney injury, pre-renal acute kidney injury, what is the first best step? The first best step is to stop the offending medication, whether it is a non-steroid anti-inflammatory drug or whether it is AC inhibitor, whatever it is, stop that. Now, the next one is, which is also part of the best, but this next step is, should I hydrate the patient or should I decongest the patient? Now, it really depends on what type of pre-renal I'm dealing with. What is the cause? If it is dehydration, obviously I'm hydrating. If it is CHF, cardiorenal syndrome, now I'm using diuretics. Good? We're moving on. And obviously, the cause should be dealt with, or the driver, like hemorrhage, GI loss, sepsis, whatever it is. Based on that, we approach. All right, so intrinsic. Again, common triggers. When should we suspect? When should we suspect? We know now the pre-renal. We know, right? The patient will have those characteristics. Dot. Remember the dot? And also the sepsis and CHF, right? And the FEA will be less than 1. So if I see that, it's pre-renal. How do I know about the past? The patient will be old, the patient will have surgery, the patient will have suprapubic pain and palpable bladder, and also the patient will have anuria, no urination. So in that case, it will be positive. Now let's talk about renal. When I can suspect my patient has renal. So if my patient has sepsis and shock, if it is prolonged and treated pre-renal acute kidney injury. If you have somebody who has pre-renal, obviously if you don't treat it, it's going to progress to renal. And then patient will fail, the kidney will fail. Nephrotoxin. What are the nephrotoxin? Aminoglycosides like gentamicin, amphotericin, radiocontrast. And if I see the pigmented nephropathy like rhabdomyolysis and hemolysis, like RBC cast and so on and so forth. So the urine clues, if I see this pigmented granular cast, if I see this, I will suspect renal acute kidney injury or intrinsic acute kidney injury. If the urine sodium often more than 40, it is okay, but the most common is this one, which differentiated from pre-renal. Remember, FE and A is less than 1 and pre-renal. If it is more than 2, it is renal or intrinsic. Urine osmolality is less than 350, which is opposite of pre-renal. Creatinine does not rapidly improve with fluid. That's another thing. Okay, management. Management is usually supportive. Treat the participant if it is precipitant, whether it is shock, whether it's sepsis, and maintain perfusion. Stop nephrotoxin. Always stop whatever caused it. Whatever caused it, stop that. Then treat based on the whatever the reason is. If it is sepsis, obviously you start this treat the sepsis. If it is antibiotic, you stop the antibiotic, and then supportive treatment. Most important thing that we need to know in acute kidney injury is hyperkalemia, acidosis, and fluid overload. All of them are important, but most commonly tested complication is hyperkalemia. They love to test you on this one. Okay? And dialysis if complication-based indication develops. Usually, yeah, okay, so I'm not going to bombard you with too much information. I'm trying to concise it. Okay, acute interstitial nephritis, drug reaction, the high yield clues. So in acute kidney injury, we have acute tubular necrosis, we have acute interstitial nephritis, we have glomerular nephritis, we have thrombic renal disease, and so on and so forth. We have a lot. So we're talking about acute interstitial nephritis, which is part of the intrinsic acute kidney injury. In this case, if they want to test you with this one, they will test you like they give you a scenario about someone who started PPI or antibiotic or non-steroid anti-inflammatory drug, then the patient develops acute kidney injury. Not only that, the patient develops fever, rash, and the patient has eosinophilia. When you check the urine has WBC cast. Sterile pyuria is also usually used, but most commonly used one is the WBC cast. Okay. Now, fever might not be always positive. Rash might not always be positive. And eosinophilia might not always be positive. These are the triads. And if you notice, I made different colors for all of them. So fever, rash, eosinophilia, striapuria, and WBC cast. So out of all of them, these four might not always be positive. Even if you have only WBC cast and the patient is on, like recently started the PPI, non-steroidal anti-inflammatory drug, or any sort of antibiotic, and then develop acute kidney injury, and you have WBC cast, think about acute interstitial nephritis. Okay? They would make it a little bit easy for you guys and will mention this, but it's not 100%. I have seen cases that none of them were positive other than just WBC cast. That makes it a little bit hard to differentiate with other types of acute kidney injury. But just remember, recently starting PPI, antibiotics, non-steroidal anti-inflammatory drugs, blood, RBC cast, think about the acute interstitial nephritis. But I'm just saying they usually make it easy for you guys and will mention all of them. But if you don't see it, don't be shocked. Okay, don't be shocked. They might not. Best next step. So obviously, what caused it? This new medication, right? Stop it. We stop the medication and the treatment is supportive. These two things I have to mention. If you have them both in the options, let's say the option A is supportive treatment, option B is stop the offending drugs. If they ask you what is the best treatment is to stop the offending drugs. What is the first or initial treatment after that is supportive. Like, for example, offending drug is the first one, then you start the supportive therapy. But if you don't have the offending, the supportive therapy is always the first best choice. But if you have them both at the options, always stop the offending. Okay? You may have, for example, A, stop the offending drugs, and then you have supportive treatment. Obviously, you have to stop the offending drugs first. This comes first, then the supportive care. Okay? Don't forget. Consider nephrology and put a steroid. It is not 100%. You can use it. You can consider it if incomplete recovery after withdrawal happens. For example, the most important treatment in this case is to stop the offending treatment. It will help the patient and the patient will start to improve. So stopping the medication is the most important treatment. Now, if it doesn't help, we will consider steroid. If it doesn't help, we don't always use a steroid, but if the stopping offending medication does not seems to help. Not only that, the supportive treatment also, which comes after. Exam pitfall, do not wait for the full trial. Again, it's a warning. So I don't know why they call it try it. For the try it, they have to have it. If they don't have it, what's the point of calling it try it? So they have to reconsider this. But remember the way that you need to approach this. Recently starting new medication, PPI, antibiotic, and non-steroid, WBC cast. Think about acute interstitial nephritis. What do you do? Stop the medication. Start supportive treatment based on whatever is needed. And if it doesn't help, start steroid. So many patients lacks fever, so they might not have it. Rash or eosinophilia. Medication exposure, striapuria, and WBC cast is usually present. Early withdrawal improves renal recovery. So common culprit, it could be PPI, it could be beta-lactam, sulfonamides, and non-steroid. And out of all of them, PPI, and usually the antibiotic and non-steroid will be usually PPI out of all of them. WBC cast and striapuria. Okay, so for the glomerulonephritis, for this one, out of all of them, these are the best thing to remember. It makes it very easy. You have acute kidney injury, and the patient when you do the investigation, you find the RBC cast or dysmorphic RBC. You have it. But on top of that, the patient will have hematuria, the patient will have significant proteinuria, the patient will have edema, the patient will have hypertension, and creatinine will rise. So systemic feature might be present also like purpura, pulmonary symptoms, and neuropathy. But usually it is very easy to understand that if the patient has acute kidney injury on RBC cast or dysmorphic RBC, go with the glomerulonephritis. Okay. Best next step. So it is glomerulonephritis. What is my best next step? Call nephrology or the targeted serology, plan for the urgent renal. Biopsy when intrinsic diagnosis is uncertain. So this might be in the licensing exam. So what if you have it? What is your next step? And out of all of them, the best confirmatory, they will ask you best confirmatory, not the next step. The next step is to involve the nephrologist, right? Because it is out of your hand. You need to involve somebody else who's more specialized in this case. So once you do that, if they ask you what is the best confirmatory, then you go with the urgent renal biopsy. So pay attention to the wording. What is the best next step? Involve the nephrologist. What is the confirmatory diagnosis? Go with the urgent renal biopsy. Supportive treatment, obviously exam framing. So urine shows RBC cast. Stop thinking pre-renal versus acute tubular necrosis and escalate the intrinsic workup. So this is something that you need to know. Like you have to memorize it. You have no other choice. But out of all this chart, the one that I colored is most important. For example, for the pre-renal, the FENA will be less than 1. But for the acute tubular necrosis, it will be 2, and for post as well. And response, it will improve quickly. And also this one, it will be high, more than 350. This one will be low, less than 350. So that's also important. But usually if they want to test it, they want to test you on this one, and they want to test you on this one, and this on this one, and also on this one. These are very important. So bland, and pigmented. Bland RBC, pigmented cast, and bland RBC. Diuretics can confound EFA. So, okay, that's not very important. All right, so what to order first? Core test. These are the tests. Basic metabolic panel. Electrolytes for acute kidney injury. So basic metabolic panel, we do electrolytes, urea, creatinine, and trend values. CBC targeted lab based on the context, calcium, phosphate, creatinine, kinase. And urinalysis plus microscopy cast or high yield, very high yield. Because based on that, you can differentiate which type of acute kidney injury do I have. Urine culture, if infection is suspected, if not, you don't have to. Strict urine output monitoring. So always consider bedside an image. Medication review, imaging, bedside and imaging. So medication review, you cannot forget about this, which I did mention. Please pay attention. If you're dealing with acute kidney injury, you cannot forget about these medication. 90% of the time, they are the culprit. Stop them. That's it. Bladder scan, Foley catheter for F retention, renal ultrasound to assess hydronephrosis, fluid challenge is only the volume depletion. We have already talked about this. Moving on to the next slide. The management. Exam priority. So this is very important. So if you get a question, there's a very high chance of having question from this slide. Because usually they ask you, what is the management? What's the first management? What's the initial management? What's the next step in the management, right? So the immediate action, stabilize hemodynamic and oxygenation. Based on options, you need to be smart enough to go with that. Stop nephrotoxin and adjust renally cleared drugs. Rule out obstruction and decompress promptly. Obviously, if this obstruction, whether you do whatever you do, is not going to improve the patient's condition unless you do the decompression. Restore perfusion of pre-renal, decongest of the cardiorenal. If cardiorenal, it means whatever is causing the acute kidney injury, I mean the cardiac or the heart is the main reason for the acute kidney injury. That's why they call it cardiorenal syndrome. It means heart fails first and it causes the renal to fail as well, or it just progress to renal failure. So complication management, again, on the top of your list in the complication of acute kidney injury has to be the hyperkalemia. Okay, acid base and fluid overload, sodium restriction, diuretic if responsive, consider dialysis when complication-based indication. The pearl is creatinine is the marker. Dialysis triggered by life-threatening complication. If you have a complication of a few things, let's say you have dehydration, you have non-steroid anti-inflammatory drug, and this and that, and then you have to think about dialysis. If you have a complication of combination of a few things. Now, high yield acute kidney injury scenarios, very high yield. If they want to give you a scenario, they will choose these points, these clues, and these clues. We can call it clues. So they will mention these clues. For rhabdomyolysis, they will give you a pigmented nephropathy, heme positive urine with a few RBC. If you see heme positive, think about rhabdomyolysis. Okay? Not only that, they will give you heme positive in urine with a few RBC. They will give you high creatine kinase, hyperkalemia. The best early step is aggressive isotonic fluid. Remember this might be in the licensing exam. I make it red. So you know that if it is heme, if it is high creatine kinase, hyperkalemia, my patient has acute kidney injury, right? But what kind of acute kidney injury? Rhabdomyolysis. What type of this? Pre-renal, renal, or post-renal? It is renal. So if it is renal, if it is a rhabdomyolysis, what do I do? Aggressive isotonic fluid therapy. Atheroembolism. Atheroembolism, delayed acute kidney injury after angiopathy. So it will happen, but it happens a few days. Like, for example, the patient had a surgery, the patient had trauma to the vascular, any large vasculature structure, and then the patient developed acute kidney injury. Not only that, the patient developed livedo reticularis, eosinophilia, and bland urine. And this is how it looks like. I have a big picture. I can't show you now, but I can show you when we were doing the cases, okay? And this looks very characteristic to, it is very characteristic to atheroembolism. The rash that you can also see in acute interstitial nephritis is completely different. I will show you the both picture and I put it side by side that you can differentiate them, because in both cases you have eosinophilia. And that makes it a little hard, because if you have acute interstitial nephritis and the patient has rash, and you have atheroembolism and the patient has also reticular livedo reticularis, acute kidney injury. So in that case, these two rash, how can you differentiate it? If you remember it, if you see it, then you can remember it. So this is a livedo reticularis, okay? And usually it happens a few days and after surgery, major surgery, damage to the vasculature structure, or angiography. Contrast risk. This is also very commonly tested. Remember, prevent the contrast-associated acute kidney injury. Highest benefit, IV isotonic hydration. When not to contrast, especially if they want to test you on this one, since we are going to have a separate lecture about chronic kidney disease, they usually give you a scenario about somebody that who needs to go under CT scan imaging, but the patient has long history of kidney disease. Now, before going under contrast CT scan, what do you do to prevent the acute kidney injury, or what do you do that you need to prevent kidney failure? That would be to start isotonic fluid 12 to 24 hours before the imaging and continue it 12 to 24 hours post contrast. And keep on checking. If the patient's kidney is fine, then you can stop it. In some cases, even 6 to 12 hours. 6 to 12 hours before the contrast. All right, we talk about this. So remember for the contrast, remember IV, isotonic hydration. So hepatorenal. For the hepatorenal, since we did discuss about cardiorenal. So the patient had CHF or issues in the heart, and that lead to the renal failure or acute kidney injury. Not failure, but on the way to fail. Same thing happens with the liver. So the patient has liver damage. Now the liver damage should slowly progress to renal damage and failure. That's why they call it hepatorenal syndrome. So for the hepatorenal syndrome, remember, if they want to test you, they will test you on this one. They gave you a scenario about somebody that who has, let's say, cirrhosis, liver cirrhosis. Now the patient has acute kidney injury. So what is the best treatment? It will be albumin. Okay, albumin. Dialysis not started for creatinine alone on MCQ1. Again, you have to, if you notice, I mentioned that if you have a combination of a few things, not just the creatinine itself, if you have a combination of things, creatinine is abnormal, dehydration for a long time, the patient is not getting enough treatment or not compliance with the treatment, the patient is getting the patient had persistent or uh, unresponsive, the patient is unresponsive to the treatment, and so on and so forth. If you have a combination, for example, I think we have it here, hyperkalemia, acidosis, pulmonary edema. So you have combination of a few things. Refractory hyperkalemia, remember this one is very commonly tested, severe metabolic acidosis, clinical deterioration, pulmonary edema, and uremic complication. So uremic complication, so these are the time that you can do renal replacement therapy. For example, if you have hyperkalemia, but your hyperkalemia is not responding to the treatment, you're treating, but the patient is not improving. So severe metabolic acidosis and the patient is getting deteriorated. Not only that, the patient develops encephalopathy, pericarditis, and bleeding. Out of all these, commonly tested is encephalopathy, pericarditis, and bleeding. So if they want to test you on RRT, which is renal replacement therapy, they will give you a scenario about somebody with an acute kidney injury who not only not improving, the patient is developing encephalopathy or the patient is developing pericarditis. So encephalopathy, pericarditis, bleeding, these are commonly tested. And out of all these three, these two are very, very commonly tested. Like if you have 4 case from acute kidney injury, I'm just saying 4 or 5 case of acute kidney injury, pericarditis encephalopathy might be one of those cases. I mean, uremic complications. So certainly dialysable intoxication when clinically indicated. So this one I mentioned. So these are not important because they're not asking you for the percentage, but I had to put it. Now, common MCQ1 traps and how to avoid them. So do not miss the obstruction. Always consider post-renal. Remember, as soon as you diagnose acute kidney injury, the next thing that you need to do is it the obstruction? Is it post-renal? You have to go after post-renal first. Why? Because it's reversible and it quickly improves. The patient quickly improves. Just by applying a Foley catheter, the patient gets better. Okay? So as soon as you diagnose, go after the post-renal. Is it obstruction? And you know the obstruction, right? Assuming all acute kidney injury needs fluid, they don't need fluid in all cases. And I gave you a scenario about CHF, right? Or pulmonary edema. Overtrusting the FENA, diuretics and chronic kidney disease can confound use urine sediment and overall context, continuing nephrotoxin. Obviously, as soon as you diagnose it, you go after, and you obviously ask the patient, are you taking any sort of medication? The patient says yes, whatever it is, just stop it. Especially if it is PPI, if it is Sadman. Sadman, I think I do have the mnemonic. Sadman is the whole thing. We can discuss it when we are doing the cases. ignoring urine sediment. You cannot diagnose acute kidney injury if you don't know the urine sediments. So basically, if you know the sediments or the urine sediments, you can diagnose and you can pinpoint what type of acute kidney injury I'm dealing with. So if you have granular cast, it is acute tubular necrosis. If you have WBC cast, it is acute interstitial nephritis. If you have RBC cast, it is acute glomerulonephritis. And for the analysis of the analyzing for the creatinine alone. So we don't do just creatinine. We have to check for the urea. We have to check for the hyperkalemia. We have to do the metabolic panel and so on and so forth, and G4 and so on and so forth. Pulmonary edema. So missing delayed arterioembolism after angiography, livedo reticularis, and eosinophilia suggests cholesterol emboli. Remember this. This will be in the might be in the exam, not will be. So I made it very simple. I just made this slide last night. It took me a lot of time, but I made it because if you have this slide and you know the sediments, the urine sediment, it is super easy to differentiate. Very easy. If you have heme, plus urine few RBC, then what is it? It is rhabdomyolysis. If you have bland sediment, usually bland sediments are pre-renal and post-renal. So RBC cast glomerular nephritis or dysmorphic. WBC cast usually acute tubular necrosis. Cloudy urine, it's very non-specific, commonly WBC, bacteria, crystal, or protein confirmed with a microscope plus culture. So granular cast tubular injury, granular, and pigmented granular cast severe tubular injury, pigment nephropathy. Remember this, memorize it. Now, I give you 3 cases because we are dealing with the 3 types of acute kidney injury. You have elderly, you have vomiting, you have orthostatic changes, you have low urine, you have concentrated urine. Creatinine is doubled. So if creatinine is more than 1.5 of baseline or normal range, it is acute kidney injury, right? In this case, the creatinine is doubled. It is twice. So we have acute kidney injury. And then we have an elderly. My elderly patient has vomiting. So if the patient has vomiting, it means the patient is losing fluid. So my patient might have dehydration. What supported? The patient who has orthostasis. And what else supported? Low urine, sodium, concentrated sodium. So my patient has pre-renal, acute tubular necrosis. Pre-renal due to what? Dehydration. So what's my next step? Since it is due to dehydration, I will start fluid and hold any nephrotoxin if my patient is taking. In this case, he's not taking any, so just start the fluid. But if he is, stop it. Whether it is non-steroid, whether it is SA inhibitor, whether it is AC, ARBS. Now, case number 2, I have sepsis. If you have sepsis, think about pre-renal and renal. Okay. Pigmented granular cast. If it is pigmented, it's not pre-renal. Pre-renal is usually bland. So pre-renal is out. Now I have pigmented granular cast. Pigmented granular cast is usually acute tubular necrosis. I know this. Why? Because I memorized the segmentation. So the FEA is 3. So if it is 3, obviously it is not pre-renal because pre-renal is less than 1. This one, a renal, is more than 2. So it is 3. It makes sense. It is more likely to be renal than pre-renal. So I know my patient has sepsis. Now my patient has pigmented. This one is also 3. And what should I do next? I have to treat the sepsis. Why? Because this is the cause of the acute tubular necrosis and supportive treatment. Good. Pre-renal, renal, finished. Now I'm going to the case number 3. I have a patient with benign prostatic hyperplasia. The patient not only have big prostate, the patient has suprapubic pain, and the patient hasn't urinated. Also, high residual volume, and the patient has bilateral hydronephrosis. What happened? So there's an obstruction, right? So it's post-renal. If it is post-renal, what do? I decompress. I apply the Foley catheter, and my patient will improve and get better. So the five move approach, rule out obstruction early. How do I do that? By ultrasound and imaging. So basically, obviously, we did the history. History itself is not enough. It is 60% enough. But if I do the ultrasound, it will give me 100% diagnosis. If there's hydronephrosis, I have it. Then I do decompression. Assess perfusion and volume, pre-renal versus congestion, stop non-street and review the AC inhibitor, ARBS, and diuretics. Check urine sedimentation, granular cast, WBC cast, RBC cast. We know that, right? So treat the driver, whatever caused it, treat that and treat the complication. Usually the hyperkalemia and acidosis. Out of all of them, hyperkalemia will be very commonly tested. And that's the end. I hope you guys